This is our third session of our Taking the Pain Out of Pain Management series. Today, we'll be discussing the pharmacological management of pain, and we will be getting started. I think we'll go ahead and get started now. And before we begin, I will just take a pause here. we would like to do a land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and most recently, the Mississaugas of the Credit River First Nations. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. We are here today for the Palliative Care Echo Project. The project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development. And we would like to send a special thank you to Health Canada for their financial contribution to the Palliative Care Echo Project. Thank you. And as I mentioned earlier, my name is Amanda Tvelda, and I will be your host and moderator for today. And our guests are Sue Martin and Laura Bates. Sue, I'll turn the floor over to you.
Okay, thank you. Welcome, everyone. I'm Sue Martin. I'm a palliative care pain and symptom management consultant with North Simcoe Muskoka. Thanks for being here and joining us. And thanks, Laura, for helping us out with the chats. We will ask you to provide us with a survey at the end of the presentation. Amanda will remind us all about that, I'm sure. And I just wanted to make note that this presentation's focus is on the adult population. The pediatric population has its own unique challenges and interventions for pain and symptom management that are beyond the scope of this presentation. By the end of this session, we hope that participants will be able to understand pain and its complexities by reviewing the types of pain, understand the principles of pharmacological pain management. We hope to advance your understanding and inspire your approach to the art and science of palliative and end-of-life pain management. It is important that each professional be responsible and accountable for having knowledge, skill, and judgment. We need to understand the principles of pain. We need to know how to assess pain, its complexities, and treatment modalities, both pharmacological and non-pharmacological. We need to know the analgesics and their side effects. So ask yourself, do I know what to do in the event of an emergency, such as respiratory depression, decreased level of consciousness, systemic toxicity, inadequate pain management, or what to do for bowel care? Next. So pain is recognized as a multidimensional experience with sensory, affective, cognitive, and behavioral dimensions. Other descriptors for pain may include distressful, suffering, complex, and pain can reflect past experiences. Pain is associated with actual or potential tissue damage. Pain is an unpleasant sensory and emotional experience. It is whatever the patient says it is, and pain is subjective. Management and assessment of pain is complex and influenced by physical, social, spiritual, emotional, and cultural factors. It can define human suffering if uncontrolled, reducing quality of life and increasing the burden of fear. So the pain pathway, this may look familiar to you. The pain pathway includes 4 components: transduction, transmission, perception, and modulation. I'm not going to go into this in depth. Please review the previous presentations on the types of pain, which is the first in the series, for more review on the pain pathway. This image represents the type and classification of pain. Again, please refer back to the previous presentations for further detailed information. But when we're looking at this image, think about why we need to understand the kind of pain that your patient is experiencing. Pain can be classified as nociceptive, non-nociceptive, or neuropathic pain. It can be persistent or chronic pain, or acute pain. It can be mixed pain or even total pain. There are specific pharmacological interventions available that are dependent on the specific type of pain that your patient is experiencing. So we're going to do a little pain management overview. With respect to goals of pain management, it's imperative that we listen to the patient's expression of pain and the impact of that pain on their life. Each person's experience at end of life is unique. Some people do not experience pain at end of life. The goal of quality pain management is to focus on alleviating disease symptoms and improving quality of life. Pain management is multifactorial and may require many different interventions. We have to understand what the patient's goal for pain management is. And today we're focusing on the pharmacological management of pain. Barriers to effective management of pain can be related to the healthcare provider, the patient, and the families. It can be very complex, related to education, understanding pain and treatment modalities, attitudes, beliefs, expectations, and the many myths still present around the use of opioids. And sometimes we give low priority to symptom management. Healthcare providers have been shown to underestimate the level of pain that a patient is experiencing, and this discrepancy widens as the pain increases in severity. Family tend to overestimate the pain in their loved ones. So the patient, if competent, should be the prime source of information about their pain. If we fail to manage pain effectively, it may result in needless suffering and poor quality of life. Up to 85% of pain syndromes can be relatively well controlled with adherence to the basic principles and guidelines of pain management. If acute pain is not well managed, physical changes in the pain centers of the brain occur and may lead to chronic pain syndromes. For example, if at the time of an amputation of a limb, if the pain has not been well managed, there's a higher incidence of phantom pain. Some special considerations to keep in mind include neurotoxicity, assessing pain in the cognitively impaired, assessing a person who is unresponsive, those with liver and renal impairments, the frail and elderly, someone in a pain crisis, and those with addiction or substance misuse disorders. Under medication selection, there are many, many different medication options available. Choosing the most appropriate medication for the type of pain your patient is experiencing is an important step. The WHO ladder, you've probably all heard of the WHO ladder, the World Health Organization ladder. This is a revised analgesic ladder, and it was found in an article in the National Library of Medicine published April 2023. Dr. Marco Cascella designed this figure. The WHO analgesic ladder specifies treatment on pain intensity from simple analgesics for mild pain with an ESAS score of 1 to 3, to opioid analgesics for moderate, which is 4 to 6 on the ESAS scale, and severe pain, which is 7 to 10. Adjuvants for pain can be included at each level, and you start at the most appropriate level. The limitation of the original scale was that there was no inclusion of non-pharmacological treatments into the therapy path. Consequently, a 4th step was added to the ladder. It includes numerous non-pharmacological procedures that are strong recommendations for treating persistent pain, even in combination with strong opioids or other medications. This step encompasses interventional and minimally invasive procedures, for instance, epidural analgesia, local anesthetic drugs, nerve blocks, ablative procedures, or palliative radiotherapy, just to name a few. This updated WHO ladder focuses on the quality of life and was intended as a bi-directional approach, extending the strategy to treat acute pain. For acute pain, the strongest analgesic for that intensity of pain is the initial therapy, and later toned down, whereas for chronic pain, a stepwise approach from bottom to top may be employed. However, clinicians should also provide de-escalation of treatment in the, in the case of chronic pain resolution. We're going to move on to principles of medication use. So with regards to opioids, there are some really important principles to keep in mind. We talk about by the mouth. So oral administration of opioids are the first choice. They're convenient, they're non-invasive, they're cost-effective, and they're very well tolerated. By the clock, so regular dosing around the clock combined with breakthrough doses ensures a steady state and a plan for managing incident pain. Steady state occurs when the rate of drug availability in the body and elimination from the body equal one another. It takes 4 to 5 doses of a regularly scheduled drug to reach steady state. This is important because steady state concentration of a drug is necessary for adequate symptom management. To maintain steady state, the medication should be ordered at regular intervals that are usually equal to or less than the half-life duration of the medication. So immediate release morphine and hydromorphone have an approximate half-life of 4 hours. Continuous relief preparations have an approximate 12-hour half-life, and some preparations have a very long half-life, say 24 hours. Therefore, to ensure steady state, most IR opioids should be ordered with a frequency of every 4 hours PO. When we think about around-the-clock dosing, also think about peak serum levels. This is important information to determine the timing of administration. For instance, peak serum levels for an oral opioid is 1 hour. Therefore, the patient who has pain with morning care or a dressing change should be given that PO analgesic 1 hour prior to care. Peak serum levels for sub-Q opioid is 20 to 30 minutes, and for IV opioids, peak serum level is 5 to 6 minutes. By the ladder is another principle that we follow, and this refers to the WHO ladder and initiating treatment at the appropriate step, as we discussed earlier. Remember that each person's experience is different, so we need to consider the individual, consider medication route, age, any comorbidities, prior opioid exposure, and remember to discuss the person's individual goals. Many people are struggling with opioid misuse due to the myths around opioids and sometimes the biases of healthcare providers. The term with attention to detail refers to assessment and ongoing reassessment. Opioid-induced constipation is a problem with almost 100% of patients. Whenever a prescription is written for an opioid, it should include a laxative as well. And of course, we need to remember the 3 rights. Ensure it's the right drug, the right dose, and the right time. Okay, we're going to move on to oral opioid analgesics. And here we have types of opioids. Codeine and morphine are natural opioids. The semi-synthetic opioids include oxycodone and hydromorphone, and synthetic opioids include fentanyl and methadone. An overview of opioids. Opioids are the major medications used for relieving pain. They're well absorbed in the GI tract and are dispersed widely in the body, and they cross the blood-brain barrier. Duration of action depends on protein binding, distribution in cerebrospinal fluid, and metabolism. They may accumulate when renal function is impaired, and tolerance may develop. Common side effects include nausea, sedation, and constipation. And there is no fixed upper dosage unless it's combined with another medication such as acetaminophen. Here are the common opioids. Hey, Linda, or Laura, sorry. Here are the common opioids, but remember, not all opioids are equal. Morphine is the medication of choice recommended by the World Health Organization and the standard against which all analgesics are measured. Hydromorphone, or Dilaudid, requires a lower dose than morphine to have the same effect. Oxycodone is often combined with acetaminophen, and codeine is also often combined with acetaminophen. Approximately 10% of patients of Caucasian descent do not have the enzyme required to convert codeine to morphine in the body. Codeine works really well, though, as a cough suppressant. We need to titrate dosage to effect, and remember there's no upper dose limit unless there is a combination medication involved. Be careful with use in elderly and people who have renal impairment. And be sure to provide health teaching to patients about constipation and the potential for nausea and somnolence in the first few days and with dose increases. And be sure to start on laxatives and get a PRN order for an antiemetic. Initiating opioids. So here are the starting doses for morphine and hydromorphone. Take note that the starting dose for someone who is frail or has poor kidney function is about half that of a usual dose. We need to start low and go slow, especially in the elderly or those with kidney or liver dysfunction. Remember to ask, is the patient opioid naive? Always check out for allergies and ask about previous experiences with opioids. And remember that oral administration should be used over other routes. Here are the starting doses for oxycodone and codeine. The lowest dose oxycodone tablets available, either in combination with acetaminophen or alone, contain 5 milligrams of oxycodone, and this is equivalent to approximately 5 to 10 milligrams of oral morphine. Remember that the doses are lower for those frail or opioid naive patients, and always provide a breakthrough dose of 10% of the total daily dose every 1 hour, PO/PRN. We're going to talk a little bit about methadone next. So methadone is a synthetic opioid. It's a potent mu opioid receptor agonist and an NMDA receptor antagonist. Methadone is highly lipophilic with rapid absorption in the upper GI tract. It has a large initial volume of distribution followed by slow tissue release, as well as a high bioavailability of about 80%. Methadone has no active metabolites, and biotransformation or chemical alteration is not required for analgesic effect. It's metabolized in the liver and is predominantly excreted in feces. Although its onset of action, next slide, please. Although its onset of action can be as short as 30 minutes, it should be avoided as a breakthrough or PRN medication due to its long duration of action and potential for dose accumulation. Use a different opioid for breakthrough such as morphine or hydromorphone. Initial extensive distribution into body fat occurs within 2 to 3 hours of ingestion, and a subsequent lower elimination phase lasts for 15 to 60 hours. It may take 5 or more days to achieve steady state, and it's approximately 10 times more potent than morphine. It's good to know that methadone is not removed by dialysis, and we need to titrate very slowly. It's recommended to have a baseline ECG and a careful review of concurrent medications completed when considering methadone as a treatment choice. Okay, next. Laura, thank you. We're going to talk about transdermal patches. So transdermal patches should be applied to non-hairy skin, dry skin on the torso or upper arm, and hold it firmly in place for 30 seconds. Heat applied to the site will enhance absorption, so avoid heating pads to the area. And we don't recommend cutting the patches in half, but be sure to check with the manufacturer's guidelines. A fentanyl patch is an excellent medication choice for persistent chronic stable pain and is not recommended for acute pain that requires rapid titration of doses. It's not recommended for opioid naive patients, and the person must be taking at least 60 milligrams of morphine every 24 hours before initiating a fentanyl patch. It's very difficult to switch precisely or titrate because of the large ranges on the reference chart. So for example, the dosage of 12 microgram patch is equivalent to 25 to 59 milligrams of morphine in a 24-hour period. A 25 microgram patch is equivalent to morphine 60 to 134 milligrams per day. Fentanyl is stored in the subsurface layers of the skin. Therefore, it first forms a reservoir in the epidermal, subdermal skin layers, then diffuses into the bloodstream, making the availability of the drug equivalent to IV or sub-Q administration. It's available in 12.5, 25, 37.5, 50, 75, and 100 micrograms per hour patches. The patch is applied every 72 hours, and it takes 12 to 24 hours to achieve a therapeutic blood level and about 72 hours to achieve steady state. Therefore, it's important to overlap by 12 hours between dosing with the previous opioid and initiating the patch. So give that long-acting opioid at the same time as the first patch is applied. When stopping the patch, delay giving a new opioid by 6 to 12 hours after removing the patch. Breakthrough doses should be available using morphine or hydromorphone, as they can be increased as the patch is increased. For a 25 microgram patch, the proper breakthrough is morphine 10 milligrams PO or hydromorphone 2 milligrams PO. And each time the patch is increased, the breakthrough should be as well. For those with mild to moderate hepatic and renal impairment, initiate treatment with 1/2 the usual starting dose, titrate slowly, and monitor for signs of respiratory and central nervous system depression. And remember that fentanyl causes less constipation than oral opioids, so the patient may require laxative doses to be reduced. Now a little bit about butrans or buprenorphine. So it's a semi-synthetic opioid stored in the adipose tissue, as is fentanyl. It's used to treat moderate to severe stable pain, not used in a pain crisis. Systemic analgesic levels are usually reached in 12 to 24 hours, but continue to rise for 32 to 54 hours. That means that we need to overlap with the previous opioid and provide PRN dosing as needed during the first 12 to 24 hours. Steady state occurs at 48 hours after application of the first patch, and terminal half-life is approximately 26 hours. The patch is changed every 7 days. Do not use it if there's a patient history of asthma, COPD, bowel obstruction, or adhesions. After 72 hours, if the pain is not well controlled, you can increase to the next strength of patch. For an opioid-tolerant patient on a daily dose of morphine 30 milligrams, a 5 microgram per hour patch every 7 days would be appropriate. And for someone on morphine 30 to 80 milligrams a day, a 10 microgram patch would be appropriate. Studies have shown that it's still safe to use opioids at a low dose for breakthrough with butrans, such as morphine or hydromorphone. Because there's a reservoir in the adipose tissue, the effects persist for at least 24 hours after removing the patch. So don't initiate a new opioid for 12 to 24 hours after removing that patch, and make sure that there's PRN dosing available. There's no renal elimination, therefore it's helpful for those with renal impairment. And it comes available in 5, 10, and 20 microgram per hour doses. The maximum dose is 20 micrograms per hour. Therefore, it's really not appropriate for someone taking more than 80 milligrams of morphine. So common side effects. Many patients will develop nausea, vomiting, or drowsiness when starting opioids or with increasing dosages. When initiating opioids, really make sure that health teaching is done to anticipate these side effects. Is there an order for a PRN antiemetic? Provide reminders to take food with analgesics, and provide cautions about the patient driving until side effects are known or that somnolence wears off. Tolerance to these side effects usually occurs within about 5 to 10 days. The majority of patients taking opioids for moderate to severe pain will develop constipation. Little or no tolerance normally develops with constipation. It just keeps happening. The most common prophylactic treatment for preventing opioid-induced constipation is a combination of stimulants such as Senna or bisacodyl and osmotic laxatives such as lactulose or Peglite. A bowel management plan should be implemented when starting opioid treatment. In the presence of reduced kidney or liver function, all opioids should be used with caution, and doses and or frequencies may need to be altered to avoid opioid toxicity, such as nausea, sedation, subtle agitation, intermittent confusion, or myoclonus. In those with reduced liver or kidney function, A palliative care specialist may be consulted for advice on opioid treatment. Other possible side effects include respiratory depression, which is really rare with proper dosing and titration. But if you suspect this, hold the next dose and call your medical provider. Pruritus can happen, so try an antihistamine, or it may require a change of medication. Urinary retention, contact again your physician or your NP. The patient may require intermittent catheterization. Myoclonus or altered level of consciousness, hold the medication and call the physician or NP. This could be opioid neurotoxicity. Breakthrough medication. So breakthrough pain should be expected, and medication should always be available. And so it's recommended to start on an immediate release analgesic for acute pain. And when the patient is using multiple doses of IR analgesic, they should be switched to a long-acting compound with IR doses for breakthrough based on 10% of the 24-hour totals given every 1 hour PRN. Use the same medication en route whenever possible. 10% is the starting dose. The ideal dose may be anywhere from 5 to 20% of the 24-hour total, depending on the response and the side effects. A breakthrough dose of IR analgesic should also be available with the transdermal patches, morphine, or hydromorphone. Titrating the dose. So we may need to titrate dosage up or down to maximize pain management. Consider down titration post-chemotherapy or radiation therapy if the goal of those therapies was for comfort. So for someone having radiation for bone mets, they may not require the same amount of opioid, and so a downward titration may be appropriate. To titrate dose up, add the total amount in milligrams of all types of opioids given over the previous 24 hours, including routine and breakthrough doses, if those breakthrough doses are being used consistently. If different opioids are being used, convert to one type using the equianalgesic table, and remember to account for incomplete cross tolerance. So titrating the dose of opioid, then you would divide the total milligrams to obtain the appropriate dose and interval to be given routinely, either every 12 hours or every 4 hours around the clock. Calculate the new breakthrough dose based on the new daily total, and continue to titrate up until pain is managed or until side effects occur. We're going to talk a little bit about end of dose failure. So 5 to 10% of patients on long-acting opioids have end of dose failure, which is where the pain worsens several hours prior to the next dose. The most common cause is an inadequate dose of the regular regime. The first step is to increase the dose without changing the time interval. If that's not effective, return to the previous dose and reduce the time interval. So if there's, say, on a fentanyl patch, you can change the patch every 2 days instead of every 3 days. Signs and symptoms of opioid neurotoxicity include sedation, hallucinations, which are usually visual, confusion, cognitive impairment or agitation, myoclonus, which is twitching or chronic spasm of a muscle group, hyperalgesia. Allodynia is defined as pain due to a stimulus that does not normally provoke pain. Mechanisms of neurotoxicity are unclear. However, symptoms of opioid-induced neurotoxicity are thought to be due to metabolites of various opioids. So for management of opioid neurotoxicity, first of all, determine if there's any other causes, and then consider hydration, if it's related to opioid toxicity or related to dehydration. Reduce the opioid dose or do an opioid rotation. Reduce the opioid dose but add an adjuvant, or change the route of administration. Treat toxicity symptomatically, so control the myoclonus with gabapentin or baclofen or a benzodiazepine. But do not use Narcan to treat unless it's due to a significant overdose. But then that patient may be put into a pain crisis. So just be cautious. This is the equianalgesic chart. And equianalgesic doses have been derived based on studies using typical opioid doses for acute short-term use. So this is the chart that we refer to. For opioid rotation is a switch from one opioid to another in an effort to improve clinical outcome. So we want to increase benefits or reduce harm, or a change in route of administration. For instance, we might need to switch from an oral to a subcutaneous. Maybe the person was on oxycodone and now can't swallow. The selection of a starting dose of the new opioid must be informed by an estimate of the relative potency between the current opioid and the new one. So that's the equianalgesic conversion. Tolerance is a normal physiological response to long-term opioid therapy in which increasing doses are required to produce the same level of analgesia. Cross-tolerance between opioids is not complete. Therefore, we need to account for that lack of cross-tolerance when switching to a different opioid and consider reducing the new opioid by 30 to 50%. So think about, when might an opioid rotation be required? Next slide, please. It might be required for someone who has unmanageable side effects, an inability to swallow, the route of administration availability or efficacy, inadequate analgesia, opioid neurotoxicity, renal or hepatic considerations. We're going to speak next about pumps. So a pump is sometimes ordered CSCI, which is continuous subcutaneous infusion, or PCA, which is patient-controlled analgesia. A pump slowly releases a prescribed medication, and that can be an antibiotic or an opioid or hydration or sedation, but it's released at a controlled rate. The basal rate is the hourly delivery of the medication, and the bolus is the breakthrough dose. Breakthrough dose is the prescribed dose at a controlled interval of delivery. So it could be every 15, 20, 30, or even 60 minutes. The patient can push the button to administer the bolus dose as often as they want, but the pump will only administer at the prescribed time interval. A pump would be indicated for a patient who is unable to swallow, perhaps, cases of severe nausea or vomiting, insufficient GI absorption, so in the event of an obstruction or maybe presence of an ostomy, cases of uncontrolled pain, or to provide the addition of sedation for intolerable pain. The advantages of using a pump include the fact that it provides the steady infusion to avoid the peaks and valleys of longer intervals between doses, and its reliable absorption as long as the tissue is unaffected. It provides improved analgesia with no clinically significant changes in adverse reactions. It's more stable serum concentration of the medication with avoidance of the end of dose interval for breakthrough pain. And there are safeguards to prevent misuse, such as a code required to access pump delivery settings, and there are alarms for any issues that may occur. So here, thank you, Laura. Here are the doses for opioid-naive patients with severe pain. So just have a look at those. And then the next slide, please. For patients already taking opioids, increase the routine dose by 25% and change the breakthrough doses accordingly. Ensure that the breakthrough doses are 10 to 15% of the daily dose, and that the frequency of breakthrough dose is every 1 hour PRN if oral and every 30 minutes PRN if sub-Q. Adjust the regular and breakthrough opioid dose every 24 to 48 hours to reflect the previous 24-hour total dose received until the pain is managed. And if there's difficulty getting the pain under control, consider a consultation with a palliative care provider. A pain crisis can occur at any time and requires prompt use of analgesics, adjuvant therapies, reassurance, and providing a calm atmosphere. Consider consultation again with a palliative care or cancer pain specialist. So if IV access is present and the person is opioid naive, you can give stat morphine 5 to 10 milligrams IV Q10 minutes until the pain is relieved. And if IV access is present and the patient is taking oral opioids, convert the PO dose to IV and administer IV every 15 minutes until the pain is relieved. Ensure that you're using a good assessment, such as the CCO pain algorithm. And just keep in mind that the ESAS score 7 to 10 indicates a pain crisis. And the goal is for the ESAS score to be reduced to 4 to 6 out of 10 within 4 to 6 hours. And then in 12 hours, the ESAS score should be down to 1 to 3. That would be our goal. If IV access is not present and the patient is opioid naive, give stat morphine 5 to 10 milligrams sub-Q every 30 minutes until the pain is relieved. And if IV access is not present and the patient is taking oral opioids, again, convert the PO to sub-Q and administer every 15 minutes until pain is relieved. Monitor carefully and titrate the dose by 25% every 1 to 2 doses until that pain is relieved. Do not try to manage a pain crisis with a long-acting opioid. That's really important. Now we're going to talk a little bit about non-opioid analgesics or adjuvants. Acetaminophen. So acetaminophen is appropriate for mild to moderate pain, such as bone pain or minor aches and fever. The maximum dose per 24 hours is 4 grams. 2.6 is the recommended maximum dose in 24 hours for the elderly over 75. And use caution with existing liver disease, someone with existing liver disease. Acetaminophen can be combined with other opioids. And when using Percocet, watch the daily acetaminophen levels and be aware of other drugs containing acetaminophen because they can accumulate. So just be aware of that. Okay, next one, please. NSAIDs, non-steroidal anti-inflammatory drugs such as Aleve, Advil, ibuprofen, Toradol. They can be used for all types of cancer or chronic pain, including neuropathic, bony metastases, or arthritic pains. There is a risk for serious GI events, so don't use or use with extreme caution in individuals with a history of a GI bleed. Decadron and NSAIDs together increase the risk of a GI bleed, as will SSRIs. Use cautiously in the elderly and individuals with renal impairment. Add a PPI, for example, Pantalop, prophylactically, if they're going to be on this for a while, and try to take food or a nutritional supplement with the medication. NSAIDs are the first-line adjuvant for bone pain. Next, we talk about corticosteroids. Is also a first-line adjuvant for bone pain and for nerve pain. For all types of cancer pain and bone pain, neuropathic and visceral pain, it works really well. Especially useful for suspected or known nerve compression or spinal cord compression and brain metastases. The usual dose would be 4 to 16 milligrams per day. It should be given in the morning as it can be stimulating. It's very useful in pain crises. Used with caution in those with diabetes and individuals with a history of psychosis. And avoid concurrent use of NSAIDs due to the 4 times increased risk of GI bleed. Undesirable effects include Cushing syndrome, mental disturbances, insomnia, depression, myopathy, and there's also an increased risk for infection or delayed recognition of infection. But desirable effects are better pain management, increased energy, and euphoria. Tricyclic antidepressants. They're useful in the treatment for neuropathic pain. TCAs block presynaptic reuptake of serotonin and noradrenaline in the central nervous system. Amitriptyline, nortriptyline are the most commonly used. The tetracyclic antidepressant mirtazapine or Remeron can also be used, but don't use with MAO inhibitors. Take them at bedtime to start. So amitriptyline could start at 10 milligrams and titrate up as high as 100 milligrams at HS. An adequate trial is required of about 3 to 6 weeks. And again, start lower in the frail and elderly. It may be sedating. There are anticholinergic effects such as dry mouth, and there may be postural hypotension. The CNRI antidepressant is, so for second line, CNRI antidepressant, specifically duloxetine or Cymbalta, is another option that we see used for neuropathic pain. Okay, bisphosphonate. They're used for bone pain from metastases, hypercalcemia, and Paget's disease to reduce the incidence of skeletal-related events in patients with bone mets. It takes several doses to have any effect on pain management. It can be taken orally, but generally they're poorly absorbed. Usually we see IV for pain relief and with a very slow infusion. Most common is pamidronate, 30 to 90 milligrams IV. It takes 5 to 7 days for peak effect. And it's usually done as an outpatient, but I know sometimes it can be done in the community. So anticonvulsants. Anticonvulsants are first-line agents in the management of neuropathic pain. Mechanism of action is still unclear. Lower doses are used in the renally impaired individuals. Gabapentin, usually the dose starts at 100 milligrams PO at HS, or sometimes twice a day, or sometimes 3 times a day. We can slowly titrate to as high as 3,000 milligrams per day. Pregabalin, or Lyrica, titration can happen a little more quickly, starting at 50 to 75 milligrams PO at HS and then increasing to BID. It can be increased to 150 milligrams BID. The maximum total dose per day is usually 300, but I have seen up to 600 total per day. Less commonly seen is Tegretol or carbamazepine. Don't see that being ordered very often. And there are a lot of drug interactions with this medication, and you really need to watch the blood counts. Common side effects for all of them are nausea, vomiting, sedation, dizziness, confusion, and ataxia. So it's a real falls risk for the elderly. So this little visual here, it's a nice visual to summarize the use of adjuvants for neuropathic pain. In the case of severe persistent pain related to pancreatic cancer, consider a celiac plexus block. The third line might include an NMDA antagonist such as ketamine or methadone, or lidocaine infusions. NMDA antagonists such as ketamine supports hemodynamic function and is not a respiratory depressant. It has shown promise for difficult to treat conditions. It can be effective in reducing acute postoperative pain, and it may reduce the overall opioid consumption. Some other medications to consider. Baclofen can be used in situations with painful muscle spasms or hiccups or colicky pain. The starting dose might be 5 milligrams BID to TID. Psychostimulants used to reverse the opioid sedation, such as Ritalin. We don't see this often, and it would be for a particular short time, but need to be taken early in the day to avoid insomnia. It's not clear if they have any inherent analgesic properties. The dosing would typically be 5 to 10 milligrams at breakfast and lunch. And cannabinoids, there's no clear evidence for use in palliative care at this time. They may have some benefit for spasms and multiple sclerosis. I'm sure there will be more information to come. Next slide. Adjuvants for visceral pain. So liver metastases, corticosteroids such as dexamethasone works really well, 2 to 8 milligrams a day, or OD to BID. With malignant bowel obstruction, octreotide 200 to 300 micrograms sub-Q TID along with dexamethasone 8 milligrams is very effective. And for colicky type pain, hyoscine butyl bromide sub-Q or Buscopan is often used. Okay, we're coming down to the case study.
So just a quick question before we go on to the case study. Somebody's wondering whether bisphosphonates are able to be given as a sub-Q infusion, say for long-term care where they're not able to do IVs. Have you ever seen it given that way?
I've never seen it given that way. That doesn't mean to say that it can't. I'd have to do some more research on that.
Okay, perfect.
Okay. Okay, so we'll move on to the case study. We have, meet Betty B. Brave, 63-year-old woman with a primary diagnosis of ovarian cancer. She's divorced. She lives alone in an apartment. She has a very supportive son, daughter-in-law, and grandchildren that live in the same town. She was a smoker for 35 years, and she has a secondary diagnosis of COPD. Next slide. Betty's PPS is 50%. She's reporting abdominal pain. And according to the ESAS scores here, Betty has some very concerning symptoms. So her pain is 8 out of 10, nausea is 8, lack of appetite is 5, tiredness is 6, depression is 6, anxiety is 7, sense of well-being is 6. She's not terribly bothered with drowsiness or shortness of breath, but she has constipation 6 out of 10. So that they're all very significant. Her current pain medication, next slide, is Percocet, 2 tabs, PO, Q4H routinely, and Statex, 5 milligrams PO, Q4H PRN. She's taken 8 breakthrough doses of Statex in the last 24 hours. So the physical assessment shows no evidence of thrush. Bowel sounds are faint. Bowel movements 0 and 3, and she's got a Bristol type 1, so hard, small stools. Her pain assessment with the acronym assessment, the OPQRSTUV, finds lower abdominal pain 8 out of 10, 8 to 10 out of 10 at its worst when standing or walking. Pain is 4 to 6 out of 10 when lying down. She reports feeling of pressure with constant sharp pain, constant dull ache throughout the lower abdomen, and a sense of fullness. Betty has nociceptive visceral pain. She's diffuse all over pressure. Her pain started getting worse yesterday. She's fearful because she believes that the pain indicates disease progression. Abdominal assessments often are not done or are poorly assessed. But when you think about all of the organs in the abdominal cavity, a high-level physical assessment is very, very important. So what do you think could be causing Betty's pain? Well, I'll tell you. Constipation or fecal loading, malignant bowel obstruction, which is very common with ovarian cancer, poor GI motility, opioid side effect, or metabolic causes such as uremia, hypercalcemia, or dehydration. Remember to always look for the root cause of symptoms. Are they reversible? And is this within Betty's goals of care? Will the investigations and treatments meet her risk-benefit balance? So then think about what orders we might expect. Next slide. I would think that the physician would order an abdominal x-ray. She would need to be NPO until the results are available, and she should receive medication to manage her nausea. We could rotate her Percocet to a sub-Q opioid with appropriate breakthrough dosing. And we need to, again, ensure that any investigation or interventions are within Betty's goals for care. So we're going to do the conversion here. It sounds as though Betty's in a pain crisis with a potential bowel obstruction, and we need to switch analgesic to a sub-Q route. Whenever we're switching the route and dosing, we need to ensure frequent reassessments occur. In order to determine the total amount of opioid Betty is taking in 24 hours, we need to convert the oxycodone to morphine. When we do this, we consider the lack of cross-tolerance between oxycodone and morphine. Cross-tolerance is 30 to 50% of total dose of oxycodone. Remember, tolerance is a normal physiological response to long-term opioid therapy in which increasing doses are required to produce the same level of analgesia. Cross-tolerance between opioids is not complete, so we need to account for that lack of cross-tolerance when switching from oxycodone to morphine. So we're going to use a 50% reduction in dose. Realistically, though, we would likely use a 30% because she's in a pain crisis. But for teaching purposes, we'll stick to 50% and make it easy. So 50% of 60 milligrams of the oxycodone is 30. So your total 60 milligrams of oxycodone minus 30 equals 30 milligrams of oxycodone. Now we need to convert the oxycodone to morphine. So we're looking at our equianalgesic chart. We see a 2-to-1 ratio. Therefore, 30 milligrams of oxycodone equals 60 milligrams of morphine. Next, we need to determine the total amount of morphine in 24 hours. So 60 milligrams, which is the converted oxycodone, plus 40 milligrams, which is the Statex, equals 100 milligrams. We've included the breakthrough doses because she's been taking them consistently. So Betty was taking 100 milligrams of morphine in 24 hours. Okay, next slide, please. So next, we need to change the route of administration from oral to sub-Q, which is a 2-to-1 ratio due to first pass, where the drug administered orally enters the liver, and then extensive biotransformation occurs, resulting in a decreased bioavailability. So first pass is why we divide the oral in half. So we have 100 milligrams PO divided by 2, which equals 50 milligrams sub-Q. We know the frequency will be hourly because Betty's going to go on to a pump. And to determine hourly dose, we divide the 24-hour total, which is 50, by 24. So 50 divided by 24 equals 2.08 milligrams per hour. I'm going to round down to 2 and make sure that we provide that breakthrough dose, 10% of the 24-hour dose, which is 5 every hour, or 2.5 every 30 minutes. Or we could do 1.7 every 20 minutes. I would be accessing my multidisciplinary team to help me with this as well. The key to great pain management is ongoing assessment and a multidisciplinary approach to care. In the case of Betty B. Brave, we incorporated these principles using a patient-centered approach to care. Her pain was reassessed and results were discussed with the multidisciplinary team. As a result of improved pain management, all of the other symptoms of concern on the ESAS-R, so nausea, tiredness, sense of well-being, appetite, depression, anxiety, and constipation, they were all addressed and reduced in severity. These actions resulted in improved symptom management and improved Betty's quality of life. And that is the end of the presentation. I hope you enjoyed today's session. If you have questions, we have a few minutes maybe, but if you could complete the satisfaction survey, we would really appreciate it.
Thank you so much. That was a fantastic presentation.
Thank
Laura,
you
did we get all of the questions out of the chat there?
I believe we did. There was just one comment also about that in many areas, nurse practitioners are providing the direct pain management prescriptions, not just physicians. And yes, that is becoming more and more common. I find that nurse practitioners are a bigger part of the pain management team.
Mm-hmm.
Well, I wanted to take a moment, obviously, to thank you both so much for being with us today and to leading the conversation. This has been fantastic. Also, a quick reminder to everyone, we have a special presentation coming up next month on the PPS scale. So if you haven't registered for that, please feel free to hop on our website and get registered. And the next session of this series will be in November. So we hope to see you there. Have a great day, everyone.
Thank you, everyone, for coming.